Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today we are joined by Dr. Arthur Sitt, Professor of Ophthalmology and Glaucoma Specialist, also the chair of our research department here at Mayo Clinic. We are going to have a journal club today, and we're so excited to have you, Dr. Sitt.
Thank you, Andrea. It's a pleasure to be here, and I'm really excited to be talking about some exciting new research in the glaucoma space today.
We picked out two articles that are hot off the press this year, two new glaucoma articles, one from the Journal Ophthalmology and one from Ophthalmology Glaucoma. And I really realized how much I love glaucoma reading these articles. It was a struggle, I'm not going to lie. So I'm so glad you're here.
What struck me is it's interesting how over time, how much our literature has gone from small case series to try to describe things into bigger and bigger data.
Big data.
And large databases. So you've brought these two. Quick summary on why you picked these two, and then we're going to get into them.
Well, I picked them because they really highlight some of the things that we don't know about glaucoma. So, if you go back into the 1980s and earlier, glaucoma was high pressure. That was it. And since then, we've become more nuanced, and I think these two really demonstrate even more than nuance to glaucoma, and really how we have to start thinking beyond just giving drops to lower IOP.
Okay.
That's a good point. I think after reading these two articles, I have more questions than I do answers about glaucoma. So let's start with the first one. This is long-term systemic use of calcium channel blockers and incidence of primary open-angle glaucoma. This was published in Ophthalmology Glaucoma just in 2024, just this past year. And it's from the group from University of California, San Diego, Dr. Sally Baxter. The primary author is Dr. Tavakoli. And the purpose of this study was to evaluate the association between the systemic use of calcium channel blockers and primary open-angle glaucoma using a big nationwide data set. And some of the background is that they've looked at the association of calcium channel blockers, but it's been in fairly homogeneous groups. And so using this specific data set, this All of Us data set, I believe, that they used, the point was to be able to capture a really diverse patient population and make sure that we're getting across multiple patients to see if there's any association between using calcium channel blockers and open-angle glaucoma. So they had a huge group of subjects in this. It was a retrospective cohort study, but they had over 200,000 people in this All of Us data set. And then they looked for those who had a diagnosis of open-angle glaucoma. But then I thought, which was well done, they wanted to have the use of calcium channel blockers precede the diagnosis of open-angle glaucoma. So patients who are on these CCBs before being diagnosed with glaucoma. And then they looked at all kinds of risk factors for the development of glaucoma in this data set and found some interesting conclusions. I'd love to hear your take on the methods and the use of the data set, if you don't mind, Dr. Sitt, as we kind of go through the article.
Absolutely. So the All of Us database is something that's been run by NIH for a number of years. And really, as you mentioned, the goal of it is to have something that is representative of our diverse population in the United States. A lot of other studies tend to have smaller sample sizes. They're biased by the particular region where they're drawing patients from. Similarly with studies from other countries, they may have very homogeneous populations. But the All of Us data set really is meant to represent all of us and who we are as a nation.
The comment on why they chose to, with a particular interest, look at calcium channel blockers, can you speak to that? Because at least in the discussion of the manuscript, they highlight there's been conflicting thoughts over which medications either are protective or put you at higher risk of developing glaucoma. Why are they honing in on calcium channel blockers? Give us a background there.
Yeah, so it's actually a fairly recent finding that calcium channel blockers may be detrimental to patients with glaucoma or to the risk of developing glaucoma. If you look back into the 1990s and early 2000s, there was this idea that calcium channel blockers may be good for glaucoma, both as a topical agent where it lowers IOP, but also potentially as a neuroprotective agent. And it was only more recent data using these large data sets where people started to detect that patients who were on calcium channel blockers seem to have a higher risk of developing glaucoma. The one study that really kind of immediately preceded this was from the UK Biobank, which is another large data set, but again using UK data. So this is kind of a follow-up to that using US data.
One thing I thought was tricky to parse out, which you kind of mentioned, is that there's some systemic medications, antihypertensive like beta blockers, other medications that should decrease the risk of glaucoma. And then we think that calcium channel blockers might increase. So in this study, they collected data on all types of antihypertensive used. So they collected data looking at whether they were using ACE or ARBs, different beta blockers, diuretics, selective, non-selective beta blockers, and then they also classified the calcium channel blockers into whether they were dihydropurines or non-dihydropurines, I think. They looked at, I hope I'm saying that right, they looked at blood pressure, hyperlipidemia, hypertension, all these other risk factors. And the hypertension, I think, is going to be pertinent for the next paper we discuss, which is also really interesting. But it seems like they did a really good job collecting the data within a big data set, which is hard in general. And like when we look at CMS data sets here, sometimes I think we're really limited in terms of the actual data points that we can collect. I don't know a lot about the All of Us data set, but it seems like they were able to get individual IOP measure, like all kinds of things. And it's not an ophthalmology data set, it's, you said, from NIH.
That's
so how
correct.
did they get all those points?
So I'm not familiar with the intricate details of All of Us, but a lot of these larger studies, they do have some ophthalmology data points, and so they did take what they were able to get. They do mention that they weren't able to get visual fields,
Right.
but there are some data points that they are able to get. But the study wasn't really designed for this purpose, but because of the amount of data that they initially collected, it just is robust enough to try to look at some of these endpoints where what really wasn't the initial purpose.
It's terrific. And then they made a 1-to-4 case control ratio, which I think is also really, really good. So that's kind of the methods. Now, if we go into the results, basically, they found there's a table, and we'll link to this paper in the discussion for the podcast for everyone listening. So of the 1 million people in the data set, they had 13,000 participants who were aged 40 or above, 11,000 without glaucoma, and 2,000 with glaucoma. So then they looked at that group, and they divided them into whether or not they were using calcium channel blockers, and then they even separated out the calcium channel blockers a little further. And so they found that within the 2,700 participants who had the diagnosis of glaucoma, they looked at the average age, they looked at the blood pressure. They did find that those who developed glaucoma during the study period where they were collecting data had a higher mean systolic blood pressure and a lower diastolic, which makes sense. We've known that hypertension is a risk factor for glaucoma. And then they looked at calcium channel blockers as well, and they found they looked at those in a univariate and a multivariate to kind of see all of the different things that would potentially predispose their risk factor. And then I'm going to flip over to this table. This table 2, I think, is really the money table, where you see so many statistically significant factors related to developing primary open-angle glaucoma. So we found that female gender was higher, correct? No, yes, female was higher, being non-white, so Asian or other was significant. Age, BMI was not, but blood pressure, like we said, having diabetes, hyperlipidemia, hypertension, calcium channel blocker use was significant. And then it didn't, is this correct? It did not matter if it was the dihydropyridine or the non-dihydropyridine, the two different types of CCBs.
Right. So I think you're referring to the univariate analysis model, and so some of those do fall out in the multivariate analysis model, which I think is the next table.
Yep.
And in the multivariate analysis, the dihydropyridines remain as a significant risk factor, but the non-dihydropyridines fall out.
Do we have any idea why that might be or what the difference is when those are being prescribed? Because I didn't know that.
So, in terms of why they're prescribed, that I don't know. I'm certainly not an internist or a cardiologist, and it's been a long time since I've been in internship.
Yes.
But one of the comments that the authors did make is that it may not be a difference between the two types. It may just be because the sample size for the non-dihydropyridines was so small.
Right. There's so much more on the regular dihydropyridine. And so if we look at that table, it's the p-value 0.001 compared to the non-dihydropyridine, but the numbers are much smaller, 0.68 in terms of the p-value. So for all these things shaking out, that was statistically significant, whether they were on a calcium channel blocker for the development of glaucoma.
Correct.
But even with multivariate analysis, for listeners, the other systemic diagnoses that increased risk were diabetes, hyperlipidemia, and hypertension,
Yep.
which we've known. But I thought it was also interesting, and it was a sub-bar to this paper, as we're looking at calcium channel blockers, that there was another blood pressure medication, at least when they did multivariate analysis, that also was suggestive of increased risk, and that was non-selective beta blockers. It's striking to me that we know that hypertension increases our risk of glaucoma, but at least potentially two measures in this papers that address and lower blood pressure actually also potentially increase the risk of acquiring open-angle glaucoma. Can you just comment on that and consistency with other literature?
Absolutely. I think you're kind of getting to the punchline of the paper, and it really is a question of, as you mentioned, we know that high blood pressure is a risk for glaucoma. There's emerging data that really suggests that low blood pressure is a risk factor for glaucoma, and there seems to be this bimodal distribution whereas if you have very high blood pressure or very low blood pressure, both of those are risks for glaucoma. And the low blood pressure makes sense because you need to perfuse your eye and your optic nerve. And if your blood pressure is insufficient to do that, then you could predispose to glaucoma. Now, interestingly, if you look at some of the dementia literature, there is some suggestion there as well that low blood pressure may be a risk factor for worsening dementia. So again, you're not perfusing those small vessels in the brain, and just like you may not be perfusing the small vessels in the eye.
In the discussion, they speak to how both of these two drug classes, the calcium channel blockers and the beta blockers, have had conflicting studies in the literature, but yet it seems like the rising concern, and the most consistent one, being the calcium channel blocker issue, which is the topic of this paper.
One question I had while reading this in the discussion says that other studies have suggested that systemic calcium channel blocker usage slows the progression of POAG, like you said, particularly when administered topically, an approach employed in studies to manipulate and reduce IOP within glaucomatous eyes. So they're saying they're putting calcium channel blockers as drops?
That's been studied. It's never made it to market
I see.
Because the IOP lowering effect was not sufficient. But any of the neuroprotective studies are difficult because reduction of IOP is neuroprotective.
In and of itself,
right.
It's hard to piece out.
And then in the more wet bench type studies, then those that are looking at neuroprotection kind of remove the blood pressure, remove the perfusion issue. So it doesn't really get to the question of what happens if you lower blood pressure or lower perfusion pressure to the eye sufficient that you're no longer meeting the metabolic needs of the optic nerve.
One thing I was wondering, since there's discrepancy, and it's kind of a chicken egg situation here. Hypertension lowering the perfusion, is it changes to the vasculature? But the paper talks about calcium channel receptors being in the trabecular meshwork. So what about a calcium channel agonist? Would that at all increase outflow?
Hard to know. I don't think anyone has studied that as far as I know. I think our internal medicine colleagues would not.
They would not like that.
They would not like that. But I think, the flip side is that especially when we get patients with normal tension glaucoma, for example, where the intraocular pressure is not elevated.
Right.
I think those patients are particularly susceptible to low blood perfusion. And those are the types of patients where we probably do want to talk with our internal medicine colleagues, and if we see the glaucoma getting worse, then maybe they want to consider backing off or changing the timing at least, or the type of antihypertensive medication that they're giving.
Maybe they should live at a slightly higher systemic blood pressure. Or do you tell patients to not take their blood pressure medication at night? Is that a thing?
I do, if at all possible. Again, we from the cardiology internal medicine side, they like to have low blood pressure at nighttime, and that has definitely been associated with better outcomes in terms of stroke and heart disease. But then the flip side is, if you're not perfusing the organs that you actually want to save, then are we really doing our patients a benefit?
It's a really difficult, it's kind of a catch-22.
Does it change your, in terms of just curiosity from a drop management perspective, some people try to minimize the number of drops they're on, and obviously the timing of your glaucoma drops, things like latanoprost are in the evening, so it's in terms of people that are on daily timolol or another, in terms of their schedule, does that fluctuation in the evening doses, in addition to monitoring their managing and thinking about blood pressure associations, does it affect at all how you're currently managing the timing of drops, or not really?
It does, and I've done this for a long time. I only prescribe timolol once a day in the morning, and it's approved for twice a day usage, but there's been a lot of studies from UCSD and other places showing that timolol just doesn't work at night at all to lower IOP. And really all you're going to do is increase side effects. You're going to reduce blood pressure at nighttime when you don't want to reduce it. So using it once a day in the morning is what I recommend.
Great advice.
Latanoprost at nighttime is perfectly good. Doesn't actually have to be at nighttime. That's really just to reduce the side effects.
But it is a tug of war between the systemic blood pressure and the ocular blood pressure. One thing that I feel like keeps coming up, and this is off topic from this paper, but I did want to ask you about, is this concept of the translaminar pressure gradient, which I feel like we've been talking about for 10 years since I was a resident, or maybe longer. And I was recently at the research day at Indiana at my alma mater, and they were talking about it there too, and our residents were talking about it at our research day, and it's this constant question, and it's related to this too, because your systemic blood pressure as it relates to your intraocular pressure provides that gradient. It seems like we're still asking the same question. What's the kind of landscape about what we think about that and ways to address that in glaucoma management, I guess?
No, it's a great question, and it is a topic that we've been discussing for, I think you're right, more than 10 years now. And I think the preponderance of evidence does show that there's a association between low translaminar pressure and decreased risk for glaucoma. So the higher your translaminar pressure gradient, the more likely you are to have glaucoma, and that relates to the fact that if you have a high translaminar pressure gradient, then it's harder for the neurons to pump neurotrophic factors in a retrograde manner. You also have more of a pressure change, so maybe more shearing in the axons. Now that being said, it is an association. We have no causative data to show that it's definitely causing glaucoma. And then the other thing is, if you look at some of the population studies for translaminar pressure difference, the difference between glaucoma and non-glaucoma is not a lot. It's about 3 centimeters of water or something like that. So
super small.
And so compared to the difference in IOP that you would see for most glaucomas, it's pretty small. And we can lower IOP. We can't easily raise CSF pressure.
Right. And CSF pressure is slightly related to blood pressure. I mean, they kind of go along the same line, but they're not necessarily the same. Is that right?
There is a relationship, just because CSF pressure is related to the amount of perfusion that you get and the amount of CSF that you produce. Another question that I often get asked is, we know that lying down increases your ILP, and so the question is it bad for glaucoma patients to lie down and go
down.
sleep?
Yeah. It's bad for them to do yoga. There's a paper on that, right?
So, so IOP absolutely increases if you're lying down or if you're head down.
Okay.
Whether it's bad for you is
I see.
very unclear. There have been some monkey studies from Crawford Downs and from UAB looking at the change in CSF pressure and the change in IOP with different body positions in these monkeys. And so your CSF pressure actually increases faster than your IOP when these monkeys lie down. So you actually decrease the translaminar pressure gradient. So it may be helpful
there.
to lie down. And then some work that we did here recently that hasn't been published yet, we found that ocular perfusion pressure increases when you lie down.
Oh,
So
that sounds good.
exactly, and so that may be protective against glaucoma because you're perfusing the eye better when you're lying down to go to sleep.
Fascinating.
With all these little pieces of a puzzle, without one clear-cut smoking gun, how do you customize your treatment regimens for different patients? If somebody is hypertensive, or if someone is a very small person who runs on the hypotensive side, do you customize their treatment plans?
Absolutely, and so the patients who come in with high pressure, pressure of 35, those are fairly easy.
Easy.
You get the pressure down.
Yeah.
The difficult ones are kind of the phenotype that you described, where it's someone who's thin and just obsessed with their health, who has a pressure of 15 and they're developing glaucoma or getting worse, and those are tough patients, and those are the ones where I'll look very carefully at their treatment, make sure that for example, if you're taking beta blocker, they're taking in the morning. I do like treatments that reduce IOP fluctuations, so things like SLT can be helpful as opposed to the pulsatile dosing that you might get from twice-a-day drops like brimonidine or dorzolamide. And then in some patients, I do 24-hour blood pressures as well, looking for those nocturnal dips. And especially if they're on systemic antihypertensive medications, then I really look at that carefully, so that if I need to suggest to the internist that we change their treatment regimen, then we'd have some data to show why.
That's fantastic.
Well, you bring up variability in pressure and position, and also just
perfect
diurnally. It's a
segue.
perfect segue. Let's talk about the other one. The other paper you brought to our attention, it was also recently published in Ophthalmology of this year, and it's a paper called "Relationship Between Intraocular Pressure Fluctuation and Visual Field Progression Rates in the United Kingdom Glaucoma Treatment Study." And so this is, again, a large database group out of the United Kingdom Glaucoma Treatment Study, as I just commented on, published by Dr. Rabilio and others that summarize this information. So what you commented on, which I have assumed for some time, and maybe has been proposed in other phenotypic conditions that we experience, is sometimes it's not necessarily what the pressure is, but is it the taxing of our system by changing that pressure? So, even considering mountain climbers, when you climb Mount Everest, you slowly acclimatize, and that leads to less complication than if you try to do sudden variations and things. And so my understanding in the field of glaucoma over time has been, one of this curiosity is it not just the pressure, but is the pressure varying up and down, and in certain people, those spikes are causing more damage than the mean. So comment on the backdrop of this paper for us and why you picked it, expanding on that, and how is this set in the landscape of what we already know?
Sure. As you probably know, I have a great interest in LP variations.
Yes.
And I kind of like to talk about glaucoma as a repetitive strain injury. And so repetitive strain injuries occur if you're taxing any system in your body really beyond its capability to repair itself. So exercise is great as long as you don't overdo it. Small repetitive tasks are usually innocuous unless you do it too often, like clicking a mouse, for example.
Whatever do you mean?
Because none of us have that issue with electronic medical records. I think in glaucoma, we know that IOP fluctuates. IOP fluctuations normal, happens in everyone. But it's certainly reasonable to think that fluctuations can get to a point where they become pathologic in certain patients. And there has been a very large body of literature, all but retrospective, unfortunately, because we just have no good ways of measuring IOP fluctuations, but a lot of retrospective studies from large clinical trials in glaucoma have gone back and looked at that data and found that the greater the IOP fluctuations between visits, the more likely they are to have glaucomatous progression. And so, but because of those limitations, there's always the need for further research. And I think this is where this comes in. They have a large database of very well characterized patients. Again, that wasn't initially designed to look at IOP fluctuations, but because they have that data, they could really take a really deep dive into it.
Sounds wonderful. Let's talk about that. So this was in the United Kingdom. It said, I think 10 ophthalmology institutions gathered patients in a multi-center randomized placebo-controlled trial regarding latanoprost, and then over a series of I can't remember the full duration of the study. And then, as you commented, this was a secondary analysis. They looked back and evaluated patients in that study, either on latanoprost or not, that had a certain number, I think it was greater than 5 visual fields. So looking at visual field stability, you needed to look at only the patients that had enough of those fields. I wondered, well, is that a cohort that is different than the rest of the cohort, even in itself? But that was their way they tried to capture. So they came up with a group of patients that ended up having, I think, 213 in the placebo group and 217 in the latanoprost group. So, about 450 patients that then they followed. And then what was, I think got in the weeds for maybe some of us, that in how you quantitate stability. They came up with a lot of variables. They had fluctuating variables, and those were defined as, this ocular pulse amplitude, standard deviations, diurnal curve, and standard deviation of Goldman across all visits. And then they had the non-fluctuating IOP metrics that were about your baseline or your peak or your mean or your supine, as you've already talked about, or your peak phasing. And then they combined that stable or those metrics that are not defining fluctuating as the principal component 1 group. So then they did the analysis. So comments on that. How do you define stability, and were you happy with how they really seem to have a lot of ways that they threw at the map on how to define people that are fluctuating for people that have really stable metrics?
Yeah, and I think you really touch on an important point, and that is that we don't have a really good way of assessing IOP fluctuations right now. Typically, we'll measure pressure in a patient once every few months. And from that, we're trying to discern whether or not their IOP fluctuates. They, to their credit, they looked at a number of different factors. And there's many ways that you can try to define IOP fluctuation, and they did a lot of them, whether it's standard deviation, whether it's peak, whether it's range, whether it's, they looked at ocular pulse amplitude, which I was very interested in. There's a lot of different ways that we can try to discern IOP fluctuations. Right now, we have no way of truly knowing what IOP fluctuations are because we just can't measure it.
One of the things I brought up was they enrolled individuals, the participants for this fluctuation study were individuals that had at least 5 visual fields. And they looked at either the fluctuating metrics or the non-fluctuating metrics of that group. But I would have liked to have seen framed in the larger study if there was those similar metrics. I know obviously the people that were excluded from this sub-analysis were those that did not have 5 visual fields. But I was kind of curious if they would have been able to frame the either non-fluctuating or fluctuating cohort here with the ones that were not included in this particular study. That were part of the United Kingdom glaucoma treatment study. So that was just like, I wondered, were the ones getting that many visual fields a different group of people than the ones that were not getting that many visual fields? But
Right.
that was just
And I don't know those details. My assumption would be that those that were excluded and didn't have sufficient visual fields were simply not followed long enough.
long enough. Yep.
As we discuss how difficult it is to characterize what fluctuation means over how much time and then actually get a good measure of it, I feel like this is just begging for a biosensor of some sort. And where are we on the development of such technology? You'd think we'd be able to measure continuous IOP.
So it's one of those things that we said is just around the corner for the last 20 years.
Okay.
But I think we are at a point where it truly is just around the corner.
Okay.
There are devices that allow continuous measurement of IOP patterns on a short-term basis, so contact lens based. It can measure IOP patterns over a 24-hour period.
Cool.
That's FDA approved. It's not marketed in the U.S., but it is FDA approved and it is used in Europe. There's also an implantable pressure sensor that is being used in Europe from a company called Implant Data. There's also some companies here that are developing devices that are implantable pressure sensors, some of them with batteries. There's a company called InjectSense. So there's definitely different, a number of people working really hard to get to that. So I'm actually really hopeful that it'll be in clinical use in the next few years.
I feel like patients would love those data. Every time a patient comes in, what was my pressure? The first thing they want to know, And so if they had a continuous, like their insulin pump or,
Sure.
Glucose monitor to always know what their pressure is, I think that could really be impactful.
Absolutely. And at this point, because that one pressure measurement every 4 months is not that meaningful. I actually try to downplay with my patients, about asking about it, because
They put so much stake on it.
Exactly, but we really do need that long-term trend, and we need more data surrounding IOP.
Is there white coat IOP?
Absolutely.
Yeah.
Yep.
And I was going to say, it may be less, as we talked about before, it might be less about the pressure on any given visit and more about their blood pressure on any given visit changing or being overly treated in that sense.
It's all the things.
So in this study then, just to get to the result part of it, they had the placebo group and the treatment group. The placebo group were those that were not being treated by latanoprost. And in that group, they did find that these stable metrics, these metrics that were not trying to articulate fluctuating features, was associated with an increased rate of progression, along with central corneal thickness and normalized OAP. Remind me OAP is. I'm just drawing a blank.
Ocular pulse.
Yes, pulse
Amplitude.
amplitude. Yes, right. So in that group or in that cohort, there not surprisingly, the group of patients, the high pressure group, was an associated risk. However, both in that group and the treatment, and also in the treatment group, that stable IOP metric group was consistent with elevated rates of progression. That being said, in neither cohort, the placebo or the treatment group, that was the metrics regarding a fluctuation, variability, visit to visit or intra-visit or in the midst of a visit, did it matter, or they weren't associated with progression? Did that surprise you?
It did, and that's where I think you really have to get down into the weeds about exactly how they perform their analysis, and it gets to the issue of how do you define fluctuation. So the way that they defined fluctuation was by taking the standard deviation and then normalizing it against the pressure. And when they did that, you're absolutely correct. They didn't find that there was a significant association with IOP fluctuation. If you look at the univariate analysis that they did before they normalized the data, and I think it was in one of the supplementary tables, they actually did find that it was significantly associated with progression. So I don't know what's the right way to measure fluctuation, but one of the effects of normalizing standard deviation against the magnitude of ILP is that you actually compress the magnitude of the fluctuation when you get higher pressures.
Right.
So if you have 3 millimeters of mercury with a pressure at a pressure of 20, but then you normalize it so that everyone looks like they have a pressure of 15, you've actually decreased that magnitude.
Sure.
And then the other thing is they did find that all of these measures of fluctuation were correlated, which makes sense. I mean, you can't separate max and range from standard deviation. And then they found that ocular pulse amplitude was associated with progression, and ocular pulse amplitude is a measure of fluctuation. It's the cardiac pulse that you see, and I'm sure you've seen it when you put a Goldmann tonometer on the chippy and you just see the Myers pulsing back and forth, and that's the ocular pulse amplitude. And I think because of that correlation, that's just what fell out as being significant after doing the multivariable analysis.
Yeah, I was, so let me ask you this then. In light of that, and in light of, in the discussion, they articulate a number of papers likewise that will either suggest fluctuation matters or suggest fluctuation does not matter. Does this change your thoughts on it? Or is there still yet a question unanswered over fluctuation?
So I think the bulk of the evidence out there does suggest fluctuations matter. I think there's a clear need to better define that. But as Andrea, as you suggested, there's a clear need to measure ILP
there's
continuously.
a market for that.
Because until we have that data, we really don't know what ILP fluctuations look like in our glaucoma patients.
I'm curious, with your work in ocular compliance and scleral rigidity in your elastography work, is OPA just a proxy for compliance?
Yeah, that's a great question. And there actually is work, not that we did, but others have done, linking the magnitude of OPA to ocular rigidity and ocular compliance. So, and remember, ILP can only change if the ocular volume changes. And the amount of pressure increase is directly related to the rigidity.
Yes.
So I think all ILP fluctuations are in some way related to the biomechanical properties of the eye.
And I would think too that would also correlate to just your overall vascular compliance and health. If you have really rigid vasculopathic bad blood vessels because you're hypertensive and hyperlipidemia and all the things, maybe you have less compliance there, and then you also have less compliance in the eye. Is it all kind of part of the same pathophysiology?
Certainly we know with aging, the eye gets stiffer. Our blood vessels get stiffer.
Exactly.
So whether or not that is and we know glaucoma, of course, becomes more common as you get older. But exactly what the changes are that will make someone get glaucoma versus someone else who doesn't get glaucoma, we really don't know. Some of our work suggests that it's actually the patients who have that have less stiff tissues are susceptible to glaucoma. At least if you look at certain areas like the optic nerve head.
Because then it moves around more and it gets those straining forces. Is that right?
That's possible, but also it's possible that because if you have a more elastic optic nerve head and lamina, you may actually be concentrating the deformation there.
Oh, I see.
It's fascinating. Yeah, and in both of these
So
papers, just as
interesting.
one of the statistics we didn't talk about, but both of them found age as a risk factor. So that goes along with what you're saying. It's just, you finish these, and I'd say glaucoma is just as hard to put your
Glaucoma is so frustrating.
put your finger on both and what it is and how to
Doesn't
treat.
it drive you crazy?
Well, that's what makes it interesting.
raises my pressure.
Yes,
Yeah.
exactly. It's so frustrating to me because everything is a conundrum. The things that matter in one sense matter on the other sense. Like have high blood pressure, but have low blood pressure. Have good rigidity, but then have good compliance. It's like it really bothers me.
So no, on that note, it's just a treat to have you enjoy and thrive in this realm for us, and be able to bring these papers to us and break them apart a little bit. Thank you for sharing your expertise on these challenging topics.
Yes,
Oh, it's
thank
my
you so
pleasure.
much.
It's been a lot of fun.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more